Hi, my name's Noah Hahn, and on behalf of the ECOG-ACRIN Bladder Cancer Committee, I'm happy to welcome you to this informational session about a key pivotal trial that is just now opening. This trial is a phase 3 trial of durvalumab and chemotherapy for patients with high-grade upper tract urothelial cancer prior to nephroureterectomy. It's ECOG-ACRIN 8192. I'm joined today with our primary investigators and collaborators for this session. Dr. Jeannie Hoffman-Sensis from Johns Hopkins is a medical oncologist who is the primary investigator of this study. Dr. Vitaly Margulis is a urologist from UT Southwestern who is heading up the urology portion of this trial in particular. And Dr. Petros Grivas from the University of Washington is a medical oncologist who's heading up much of the translational work in this particular study. So thank you all for joining us today. I think for this particular webinar session, one of the main purposes is to inform our audience about the purpose of the trial, its goals, its impact, both now and in the future. So I was wondering, Dr. Hoffman-Sensis, if you might be able to provide just a brief overview of the trial, its design, and its significance.
Sure. Thanks, Noah. Thanks for the opportunity to talk about this exciting study. So this is a unique study, kind of like the POUT trial, building on the idea of the importance of perioperative chemotherapy. We think it's very important to have a clinical trial just for patients with high-grade upper tract urothelial cancer. And that's the patient population that this trial is focused on. This trial is for patients with high-grade tumors that are biopsy proven, where the patients are planned from their urologist to undergo a nephroureterectomy with the idea of curative intent. So patients coming into this trial are oftentimes going to be referred by our urology colleagues. The main driver, the main portion of the clinical trial is a large randomized portion for patients who are platinum eligible. So that's going to be a combination of dose-dense MVAC chemotherapy, either with durvalumab as the experimental arm or randomized to dose-dense MVAC alone. It'll be 4 neoadjuvant cycles of chemotherapy and then followed by a planned surgery. We'll, of course, be looking at pathologic endpoints as well as survival endpoints. There's a smaller group also for patients who are not platinum eligible, combining chemotherapy, gemcitabine with durvalumab alone, and the same paradigm, patients who are planned for surgery, they'll have that preoperative treatment and then move on to standard surgery, as well as long-term follow-up, as per standard with follow-up scans, as well as cystoscopies.
Thanks, Dr. Hoffman-Sensis. That's a great overview and obviously of this very key trial. I was wondering a little bit, Dr. Margulis, if you could kind of comment on how did we get to this point? So, this is a large trial, randomized phase 3 trial. Does this build off some prior work, and what's our experience in this space about, why we feel enthusiastic about this investigation?
Yeah, thank you, Noah. And it's a great segue to talk about the prior ECOG trial where we have targeted patients with high-grade urothelial cancer in a neoadjuvant setting with an idea to see if neoadjuvant platinum-based chemotherapy, number one, can be delivered safely prior to nephroureterectomy, and number two, produce reliable pathologic outcomes. And specifically, in the prior ECOG trial, we're able to enroll 30 patients who were given dose-dense MVAC for 4 cycles. And these patients had good GFR. In the second arm of this trial, targeted patients with GFR less than 60, and they were given gem-carbo. And what the trial has shown is, number one, that patients can safely tolerate and receive neoadjuvant platinum-based systemic chemotherapy and proceed to nephroureterectomy without undue delay or without undue complications. The overall grade 3 and 4 complication rate in this trial was 25%, I believe, without any grade 5 toxicities. And we have observed 15% complete response rates in patients that got 4 cycles of dose-dense MVAC at their nephroureterectomy. So that's quite an impressive complete response rate. So we know that this therapy is effective, feasible, and can be safely delivered. And we can talk about the arm of the gem-carbo, which failed to enroll for various reasons, and that can be a topic of a separate conversation.
Sure, no, that's really helpful to kind of know the history of sort of how we got to this particular point. I think we are seeing in upper tract disease the use of neoadjuvant chemotherapy becoming, accepted standard of care. In fact, in sort of guidelines and national meetings, we've sort of seen this brought up, and we're seeing that engagement from both urologists and physicians, which has been exciting to see. It still is sometimes a little bit relatively new to some folks, and so I was wondering, Dr. Grivas, if you could kind of just highlight for our audience, what particular patients are we trying to enroll in this study? So what are the eligibility for patients that we should be considering this study for?
Thank you, Noah. I'm very excited to work with all of you in this very, very important trial. In this particular trial, we are focusing on patients with high-grade upper tract urothelial carcinoma that was proven by biopsy within 2 months, 60 days prior to randomization. And the diagnosis comes from upper urinary tract mass diagnosis on cross-sectional imaging or a direct tumor visualization during endoscopy when it's done by urologists before referral to medical oncology. And we always recommend biopsy as a standard of care prior to enrollment of the study to document the diagnosis of upper tract high-grade urothelial carcinoma. We allow variant histologies as long as the predominant histology is urothelial transitional cell carcinoma. Patients must have adequate organ function and bone marrow function, and we measure, of course, labs at baseline screening. And patients should not have any evidence of metastatic disease or clinically enlarged lymph nodes, 1 centimeter or larger in a short axis, imaging required within 28 days prior to randomization. Patients should not have any uncontrolled illness, no active infection, no autoimmune disease within 2 years, and should not have been on immunosuppressive medication, systemic immunosuppression in the last 2 weeks prior to the first dose of treatment because of durvalumab being a checkpoint inhibitor targeting PD-L1. Overall, we look at the patients based on cisplatin eligibility, and we use cisplatin criteria to make sure the patient is fit for cisplatin, to make sure they're eligible for the first arm. And we use the creatinine clearance cutoff of 50 cc per minute. And if the creatinine clearance is higher than that, and patients have no significant hearing loss or significant neuropathy, can be fit for cisplatin. If the creatinine clearance is more than 15, but less than 50, or up to 50 cc per minute, then they can go to the cisplatin eligible arm, durvalumab and gemcitabine. Overall, I would try to simplify eligibility criteria to make it pragmatic for the study, so patients can enroll across different centers.
Thanks so much, Dr. Grivas. That's incredibly helpful. So I think what I did hear from you, though, is that there is a portion of this study that does enroll patients who are cisplatin ineligible, in that single arm of gemcitabine durvalumab. So I do think that's important, again, for our audience to know that as we open this trial, that we should consider it in really all upper tract patients out of the get-go. So that's actually very, very helpful information. And also your point about the allowance of some variant histology, I think, is a key point. That comes up in many of our trials where some patients are excluded if they have even a minor component, say, of squamous or other histology. So I think that's very helpful for our audience. I wanted to switch back, Dr. Margulis, a little bit from the urologist perspective about this particular study in this patient population. And just wanted, if you could kind of speak a little bit to why should physicians, in particular urologists who are really seeing these patients, as the point person, why should they consider this study for their patients?
Great question, Noah. And I think that there's certain baseline assumptions that are important. Number one is that high-grade urothelial cancer, particularly upper tract urothelial cancer, is very difficult to stage. Unlike the bladder cancer, most of the time, by the time it is diagnosed, it's already invasive and has very high probability of having occult metastatic disease. So that's number one. Number two, we know that platinum-based therapies are effective in this disease vis-a-vis the recent POW trial, which shows significant improvement in disease-free survival. And last and most importantly is the best opportunity to give these agents, and this includes immunotherapies and platinum-based therapies, is prior to nephroureterectomy. Simply put, by the time the kidney is removed, there's significant decline in GFR and significant a decreasing probability of these patients getting any meaningful systemic therapy. And if you look very closely at our trial, earlier ECOG trial, majority of the patients were able to get platinum-based chemotherapy and move on to nephroureterectomy. If you look at the POUT trial data, this number drops down into the 60s.
Yeah, I think it's really important, sort of just pragmatic aspects about trying to give our patients the best chance for curative potential with, you know, the incorporation of both local and systemic therapy options, and how the neoadjuvant approach sort of facilitates that a little bit more consistently. So I think that's actually some very good points, and you know, I think it really sets the bar, you know, for why we should be considering this. I want to come back to Dr. Hoffman's census a little bit here, in terms of thinking ahead a little bit. You know, we're trying to really drum up enthusiasm to get the trial going, to get it started, accrued, and get it finished. How might the results of this trial, when it actually completes, transform our approaches to these patients, and what do you hope, you know, could be the potential impact, both short and long term, of EA8192?
Yeah, thanks for that question, Noah. And I think, you know, all of us on this call have been, you know, sitting around conference tables and thinking about how to improve patient care for urothelial cancer, you know, for over a decade now. And it's hard to believe the questions that we're asking now are really these, you know, important ones. We couldn't even fathom asking them a long time ago. You know, I think one of the most important things that's going to come out of this trial is the fact that upper tract urothelial cancer, you know, really can be considered its own disease, and should. You know, a lot of what we do or don't understand about upper tract urothelial cancer comes from, you know, the data that we try and interpret in subgroup analyses. And I don't think we've done such a great job of it. And, you know, to have trials like POUT, you know, that show that you really can complete a randomized phase 3 trial in upper tract disease is important. It's inspiring. It's the benchmark, and we need to keep going. So I think that that's important. I think that it continues conversations, you know, between our urology colleagues and medical oncology, taking care of patients with high-grade urothelial cancer, either of the bladder or the upper tract. It's a multidisciplinary process, and we are constantly, you know, in communication, both from a clinical perspective as well as from a research perspective, with our colleagues in these other disciplines. And so it's important to recognize that those conversations need to happen. Even if a patient might not go on a clinical trial, I think knowing what we feel is the standard of care, knowing what we feel like is a standard conversation about neoadjuvant chemo, a standard conversation about what a lymph node dissection looks like in this patient population is important. And then finally, to really get kind of clear, defined answers with survival endpoints for this population will be important.
I don't think I could have said it any better. That was inspiring. And I think, as you point out, you know, it's a critical juncture, you know, in time for upper tract urothelial carcinoma. And I think you're mentioning about we need to treat it as a different disease, I think is well put. And I think one of the important benchmarks of this particular trial is, again, to further build on sort of the POUT study in the adjuvant setting, but to also show that these upper tract patients, number one, they're there, but number two, the investigators, physicians recognize them and, you know, are able to study them independently. You know, and I think we all believe that and have shown that before. It's an important, you know, important measure for us to accomplish. So I think we're all very, very enthusiastic about this particular study in particular. Dr. Margulis and Dr. Grivas, I just want to kind of ask you any sort of additional thoughts about the study itself, or its operational aspects that you want to mention to the audience before we close the session.
Yeah, I would say, just want to bring the very important point. I mean, I think that the low GFR platinum ineligible patients is a very important key aspect of this study, and it really allows us to bring the neoadjuvant strategy to every patient with urothelial cancer. And so that's very exciting, and there's great preclinical and clinical rationale for combining, for example, gemcitabine and a checkpoint inhibitor. So I look forward to the results of this, and it's a very exciting trial to be open.
I totally agree with Ginny and Vitaly. I think this trial definitely focuses on upper tract urothelial cancer, which is more common than we think, and we have significant diagnostic and therapeutic dilemmas in the clinic. So we're very, very excited that this trial is ongoing. It's a very important study to answer specific questions. And also, as Vitaly mentioned, we're capturing patients with creatinine clearance, as low as more than 15 cc per minute. So we allow patients with low GFR to be able to get systemic therapy. And I think that's important because we're trying to be pragmatic in the design of the study, capturing as many patients as we can and be able to apply the results in clinical practice. So this trial is opening across different sites, the cooperative groups. ECOG-ACRIN is running the study. Hopefully the study will open in multiple centers and hopefully will be accrued in a meaningful amount of time to answer the critical question, how do we manage patients with upper tract urothelial cancer and whether neoadjuvant chemoimmunotherapy should or not be the standard of care. We're very excited and thank you so much for the time today.
Thanks so much, Dr. Grivas. And on behalf of Dr. Hoffman-Sensis, Dr. Margulis, Dr. Grivas, I want to thank you, our audience, for joining us today. Again, it's EA8192. It's phase 3 trial of durvalumab and chemotherapy for patients with high-grade upper tract urothelial cancer prior to nephroureterectomy. It is open, it is accruing, it is very near to you across the country. If there are any questions about this particular trial, please do not hesitate to reach out to Dr. Hoffman-Sensis, Dr. Margulis, Dr. Grivas, myself, or other ECOG-ACRIN staff. Thank you so much.